Good evening, everyone. Welcome to the fourth online masterclass started by Jaipur Surgical Tutorial. Jaipur Surgical Tutorial is an online educational activity which we started about 2.5 years ago at the Mahatma Gandhi Medical College and Hospital in Jaipur. And this is being coordinated by my young faculty colleague, Dr. Anand Nagar. Today, he is busy with a liver transplant, so he's not present in the session. We've already done 3 master classes on living donor liver transplant, safe cholecystectomy, and chronic pancreatitis. And this one is on acute pancreatitis. These master classes are held every last Thursday and Friday of the month, 7 to 9 p.m. India time, and they are available for everyone to join for free online. So for today's and tomorrow's masterclass, the theme is acute pancreatitis, and I requested Dr. R.A. Sastry, who's currently at KIMS in Hyderabad after serving for a long time at the Nizam Institute of Medical Sciences in Hyderabad, to moderate today and tomorrow's session. Over to you, Dr. Sastry, please.
Thank you, Dr. Vinay. Good evening, everybody. And of course, welcome to the fourth master class that has become so popular in such a short span of time, and educative too. Today's topic is acute pancreatitis, and we have very good faculty who have wonderful experience in the management of this unpredictable disease. In fact, most of us in the faculty have been fortunate to have been a part of the evolution in the management of this unpredictable condition, mostly through our failures, and in the process of become wiser. So let's start this session. So what I'm given to understand is we'll have one chairperson, and of course there are 4 talks in this. So before I summarize, I think I'll ask Dr. V.K. Kapoor, because his topic itself is acute pancreatitis in a nutshell, and it's good to have a bird's eye view of the disease before you get lost in the intricacies of management, the controversies, and in depth. I think it's good to have an overview, and I understand this is mainly meant for the postgraduates and the students, the residents. So, Dr. Vinay Kapoor, please, acute pancreatitis in a nutshell.
Thank you, Dr. Shastri. So I thought since there will be some MS students also joining the masterclass, it would be good to have an overview of what acute pancreatitis is before we go into the details. So very briefly, I would touch on a few basic facts about acute pancreatitis, and then we will have more discussion in detail. So students who are participating, please note down my email address, vkkapoor.india@gmail.com. If you want to know a little more about acute pancreatitis, you can always request me for some more reading material on acute pancreatitis. So I bring you greetings and regards from the Mahatma Gandhi Medical College and Hospital in Jaipur in Rajasthan in India. And acute pancreatitis, the presentation is as an acute upper abdomen. That means the patient presents with sudden onset, usually moderate to severe upper abdominal pain, upper mid-abdominal pain. And you may think of any other organ involvement or any other diagnosis, for example, peptic ulcer, especially peptic ulcer perforation. You may think of mesenteric vascular accident. You may think of proximal small bowel obstruction. You may think of an inflammatory condition in the liver. We know that many a time biliary colic may be perceived by the patient in the mid-abdomen, upper abdomen rather than right upper abdomen. So we may think of any other possible differential diagnosis, but in any and every patient who presents with sudden onset, moderate to severe acute upper abdominal pain, mid-abdominal pain, mid-upper abdominal pain, we should keep acute pancreatitis as one of the differential diagnoses. And to illustrate my point, I show this CT scan, which is a young lady in whom the clinical diagnosis was acute pancreatitis. But when a CT scan was done to evaluate the acute pancreatitis, it was found that it was a thrombus in the superior mesenteric vein, what is seen as a filling defect here pointed by the arrow, which was being misdiagnosed as acute pancreatitis. So both ways it is possible that it is something else and clinical diagnosis is acute pancreatitis or vice versa. Now, once we think of acute pancreatitis based on clinical presentation, which is, as I said, is sudden onset, moderate to severe acute mid-upper abdominal pain, usually associated with retching, nausea, and vomiting, then we have to investigate. And the specific investigations would be serum amylase and lipase if they are elevated more than 3 times the normal of your lab. An initial ultrasound, which obviously will look at other organs also, for example, the gallbladder, the liver, if there is any free air or free fluid in the abdomen, and if it is combined with Doppler, it can even look at the vessels. And in some cases, a CT with IV contrast. I will discuss the role and timing of CT a little later. But in all these patients who present with acute severe upper mid-abdominal pain, we must always remember and do keep in mind the supradiaphragmatic, that is cardiac and respiratory causes of what is perceived by the patient as abdominal pain, but the origin is actually in the chest, and therefore a chest X-ray, an abdominal X-ray to look for any evidence of acute intestinal obstruction, and an ECG. And whenever we ask for a chest X-ray in an acute abdomen, you have to remember that you should make the patient sit up, if not stand, at least for a couple of minutes, and then do a chest X-ray, including both lobes of diaphragm. And then you would see what is seen here, the free air, especially very well seen under the right dome of diaphragm, because on the left side, you could have a dilated fundus of the stomach with air and the colon, which is full of air, and the small amount of air is better appreciated under the right dome of diaphragm. Now, CT scan for acute pancreatitis or for evaluation of any pancreatic pathology ideally should be a pancreatic protocol CT, which includes usually a no or a negative oral contrast rather than positive oral contrast, a large volume of contrast injected at a high speed, which is done with an infusion pump. Images are taken at various time intervals to coincide with the early and late arterial phase, portal venous phase, and then delayed phase, and preferably thin, even 2 to 3 millimeter slice multi-detector CT if the equipment is available. Now, it's important that for the diagnosis of acute pancreatitis, CT is not essential, because based on any two of the clinical, biochemical, or ultrasound criteria, a diagnosis can be made. The role of CT scan is more to evaluate the severity of the acute pancreatitis, which is usually manifested in the form of either necrosis of the parenchyma, peripancreatic necrosis, or local complications. And that is why it is recommended to be done not at the time of initial presentation of the attack, but after a few days, minimum 3, some people would say 5, and some units even practice as late as 7 days, so that the necrosis, if it has to show, becomes evident and becomes evident in its full form. The only situation where an early CT scan at the time of presentation of the patient would be indicated if the clinical diagnosis is in doubt, when we don't want to miss a surgical problem like mesenteric ischemia, like proximal obstruction, like an aortic aneurysm-related problem. In that case, an early CT scan is mainly to rule out a possible surgical cause or any other differential diagnosis. Or if there is a suspicion of an early complication in the form of either bleeding or a ischemic gangrene of a adjacent viscus like colon, proximal jejunum, which is causing features of peritonitis. But if you do a CT scan very early, you would only see some peripancreatic edema, as is seen here. You may see irregular outline of the pancreas and some peripancreatic fat stranding. So CT scan, early CT scan is not mandatory for the diagnosis of acute pancreatitis. It is therefore usually done after a few days of the onset of attack. Once we have made a diagnosis of acute pancreatitis, the next important step is to assess the severity of the attack. And this can be done by clinical and lab parameters, which suggest organ failure, morphological changes, which are seen on CT scan, which means a pancreatic necrosis, either more than 1/3 of the organ volume or more than 3 centimeters in size. There are several CT severity indices, including the Balthazar, and presence of local complications in the form of a fluid collection, cyst, necrosis, or abscess, depending on the duration of the episode of acute pancreatitis. There are some single parameters like CRP and procalcitonin, and there are several complicated scores like Ranson and Apache, which are used, but they are not very practical for day-to-day use, especially the Ranson and Apache. They are more used when you are doing some kind of a study or a research protocol where you want to objectively compare between groups of patients. Now, organ failure is an indication of severity of acute pancreatitis, and the organs which commonly fail are, in order of importance, respiratory, where PO2 is less than 60, creatinine more than 2 milligram, cardiovascular in the form of hypotension, and significant GI bleed. To diagnose necrosis, as I mentioned earlier, you need a good contrast-enhanced CT scan. And why is it important? So once we know that it is severe acute pancreatitis based on organ failure, then it is important to find out whether there is necrosis or not. Because presence or absence of necrosis makes a huge difference in the outcome of the patient. In the presence of necrosis, the morbidity is high. Majority or almost all these patients will have one complication or the other, and mortality increases tremendously as compared to those patients who do not have necrosis, even if based on organ failure, they have or they may have severe acute pancreatitis. So on the left CT scan, we see normal enhancing homogeneous parenchyma. On the right side, we see patchy enhancement, and most of the parenchyma is not enhancing, which suggests necrosis. As I said, to evaluate the full extent of necrosis, CT should not be done too early in the illness. It should preferably be done after 3, 5, or some groups would say even 7 days. Now, once we know that there is necrosis, the next important issue is to find out whether it is infected or not. And the risk of infection increases with the amount of necrosis in terms of percentage of parenchyma, which is not enhancing, and the duration of necrosis or the duration of episode of acute pancreatitis. And this is important because if the necrosis is infected, the mortality is almost double. And it was thought earlier that in presence of infected necrosis, if we don't intervene, then the mortality is almost 100%. But now we know that there are some exceptions to this dictum. Now, the gold standard to diagnose infection was image-guided fine needle aspiration and subjecting that fluid to gram staining and culture. But more and more groups do not do that for two reasons. One, because it could be false negative. And second, it itself could introduce infection in a sterile necrosis. And therefore, more and more groups rely on other parameters to diagnose or suspect infection, which are indirect indicators. Now, clinical features of fever, leukocytosis, etc., are not necessarily indicator of infection in acute pancreatitis because they could be present as a part of systemic inflammatory response syndrome, which is usually seen in patients with acute pancreatitis. But organ failure, which is persisting beyond first week, is usually a good indirect indicator of infection of the necrosis. Presence of air in the necrosis on CT scan is an indication of infection, and a lot of reports suggest that a high procalcitonin is also an indirect indicator of infection of necrosis. Now, based on various evaluations, the acute pancreatitis earlier was classified as mild and severe, but in between a group of moderately severe acute pancreatitis has been suggested. And in fact, one of the classification classifies pancreatitis into 4 groups. The next talk is going to cover this in more detail, but briefly, this is determined by presence or absence of local complications, including necrosis, and then whether it is sterile or infected, and systemic complications in the form of organ failure, which is either transient, that means it resolves within 48 to 72 hours with organ support, or whether it persists beyond that period. So on one end, we have no necrosis and no organ failure, which is mild acute pancreatitis. On the other extreme, we have infected necrosis and persistent organ failure, which makes it critical severe acute pancreatitis. And in between, we have moderate and severe. Now, it's important to understand the pathophysiology of acute pancreatitis if we want to manage the patients correctly. And that includes a huge amount of third space loss of fluid resulting in shock, increased intra-abdominal pressure causing even abdominal compartment syndrome, severe inflammation resulting in SIRS, translocation of gut bacteria resulting in infection of the collections and necrosis, endotoxemia, which is responsible for multiple organ failure, and over a period of time, severe catabolism leading to malnutrition. So all these things have to be kept in mind and looked after when we manage acute pancreatitis. The management of acute pancreatitis in the first 2 weeks, unless there are early complications, as I mentioned earlier, is largely medical. So it's a non-surgical disease, and it includes basically organ support. So patients with severe and maybe even moderately severe acute pancreatitis should be managed in a high dependency or intensive care unit. Their nutrition has to be looked after if possible, and as far as possible, enteral nutrition with a nasogastric or nasojejunal tube, and only in patients with severe ileus who are not tolerating any enteral nutrition, then parenteral nutrition. From vigorous fluid resuscitation, we are now coming to goal-directed fluid therapy. Role of antibiotics is very controversial. These patients have pain which needs to be looked after, and counseling of the patient and relatives regarding hospital stay, cost, and outcome, which is unpredictable, is very, very important. Organ support is mainly respiratory, inotropes, good glycemic control, renal support, acid suppression, and these patients may have hypocalcemia, which needs to be looked into. The role of antibiotics in acute pancreatitis is a very debatable, very controversial topic. There is evidence that it is not, they are not required in patients with sterile necrosis, but in practice, most groups do use prophylactic antibiotics, especially in patients who have extensive pancreatic necrosis, even if there is no suspicion of infection. And if they are used, then quinolones, piperacillin combinations, carbapenems, and they should be given at least for 14 days. There is a very controversial role of selective gut decontamination, and patients who have been in hospital for a long time, who have been on prolonged antibiotics with multiple tubes and drains, probably should receive antifungal prophylaxis. Now, the key issue in necrotizing pancreatitis is about intervention. Which patients require intervention? When should it be done? What kind of intervention? And if it is surgical, how that has to be done? So in brief, broadly speaking, the indication for intervention is if we know or we suspect that the necrosis is infected and it is causing systemic sepsis in the form of organ failure. Sterile necrosis, only if it is not responding to maximal intensive therapy over a period of time with no improvement in organ function, may be an indication for intervention. And abdominal compartment syndrome is a very debatable issue. And desperate surgery, that means when nothing else is working, your intensivist says that please operate upon the patient, is again something which is very, very controversial. Now, the standard management of necrotizing acute pancreatitis today is what is known as a step-up approach. It starts with percutaneous intervention, which in some cases could be definitive. But the most important role is to delay surgical intervention, as we would discuss, to a later period, and sometimes to handle post-surgical residual collections. There is a greater role today of endoscopic transgastric intervention using lumen opposing metal stents, which will be discussed tomorrow. And finally, surgical intervention, which could be minimally invasive or open laparotomy approach. Endoscopic intervention on the bile duct in gallstone-related acute pancreatitis, the only possible indication is severe acute pancreatitis presenting within 48 hours, or if there is cholangitis, which becomes an indication. Most meta-analyses have shown that it doesn't make any change in mortality, but probably the complications could be less. But we have to remember that this endoscopic intervention has to be done by a very, very experienced endoscopist. Surgical procedure for necrotizing pancreatitis is necrosectomy. It is not resection of pancreas. It is removal of the necrosis, which could be laparoscopic, minimally invasive, retroperitoneal, or open. The best instrument to do necrosectomy is a blunt instrument, finger or suction tip, not knife, not an energy source. And in most of these cases, one should think of a feeding jejunostomy in place of a nasojejunal tube. And in case the viability of the colon is in doubt, then a prophylactic or preventive diverting loop ileostomy. The timing of intervention, now most groups follow the dictum that you delay the surgery as far as you can using endoscopic and laparoscopic approaches, percutaneous and endoscopic approaches to buy some time, because earlier you have to operate or you operate, higher is the mortality. Surgery should definitely not be done within the first 2 weeks unless there is a complication requiring it, and preferably it should be delayed to beyond 4, and some people would say even longer than that. And one of the approaches is minimally invasive retroperitoneal approach or video assisted. And it starts with the CT-guided percutaneous drainage, and the tract is then dilated. And through that, a nephroscope or finally even a retroperitoneal open approach can be used, wherein one goes behind the transverse colon. But this is most suited for necrosis confined to the tail and distal body of the pancreas. Head of the pancreas may be difficult to handle by this approach. As I said, counseling is very, very important because by and large, patients with severe, especially infected necrotizing pancreatitis have a long hospital stay, including prolonged ICU stay. Rate of reoperation or reintervention need is very high. Costs can run very high. And in spite of all this, the mortality still remains in the range of 10 to 20%. So counseling of the patient and relatives in the beginning is very, very important. So I would like to end up by saying a patient with acute upper mid abdomen, after excluding surgical causes with whatever investigations required, we make a diagnosis of acute pancreatitis. Next step is to assess the severity, mild, moderate, or severe. And if it is severe acute pancreatitis, we have to find out whether there is necrosis. Treatment is largely conservative and supportive. If the patient improves, fine. If doesn't, then it can be an indication for intervention, which to begin with is non-surgical. And finally, in a small proportion of cases today, surgical intervention may be required. If it is acute pancreatitis, we have to find out the cause. Usually it is stones and alcohol, but if they are not there, then further investigations to find out, especially if the patient has recurrent acute pancreatitis, and that would include biochemical evaluation, MR or EUS, and finally genetic studies. So with that, I would like to end. And students, if you want to read more about acute pancreatitis, please send me a mail, vkkapoor.india@gmail.com. Thank you. Thank you very much. Dr. Shastri, please.
Yeah. Thank you, Dr. Vinay. I hope you all got the pearls of wisdom from the brief summary of acute pancreatitis, which is important. See, if I have to further summarize, what we have learned in these 3 decades is basically, apart from the diagnosis, where it is mainly by exclusion of the surgical conditions which require urgent intervention. As a surgeon, it's important to rule out the conditions which would require urgent intervention. Second is, now we have a clear definition of what we are talking of. See, that clear definition of the terms which will be dealt in a little more detail. The third is, we're able to stratify the disease in its highly varying severity, thanks to the imaging, the organ failure scores, and the advances. So it's important to stratify it into mild acute pancreatitis, which does not require any critical care, or severe acute pancreatitis, or in between. We are also able to identify the severity is not just by the biochemical scores, but by imaging. I must emphasize here, you should be absolutely clear in your CT analysis, in identification of the spaces, the peritoneal spaces and the extraperitoneal spaces, whether there is necrosis or no necrosis, and the complications. Is there infection, or the signs of infection in terms of gas, in terms of say hollow viscous perforation, or any impending bleeds? See, these are the important things which you would see by the CT. And with all this, we are able to define the treatment strategies, basically non-interventional and interventional, and the right time for an intervention. The other important thing which we have learned in these 3 decades is, we have learned to intervene with the least disturbance to the complicated physiology of acute pancreatitis through minimally invasive approaches, the endoscopic, percutaneous, laparoscopic modes, and tailor our interventions through multidisciplinary care and using the best use of our local resources. Well, if I have to summarize, I think these are the important things which you would remember, and these would be dealt with in a little more detail now. I think we'll go to the topic. Dr. T.D. Yadav.
TD says that he has just finished the OT. He will take a few minutes. I think you can please carry on.
Okay. So we have Dr. Anand Nagar.
No, Dr. Kulbhushan will be doing.
Dr. Kulbhushan will be dealing with the definitions, the nomenclature, and the current classification of acute pancreatitis, which is very important, because this is what is, it would lead you to the treatment strategy and compare your results with others. Dr. Kulbhushan, please.